Hello and welcome to another episode of The Frontline with Gary Payenda. We've got a really good show for you today. I just finished reading this book, A Dim Prognosis by Ivor Popovich, and we've got Ivor online from the UK, and he's going to give us an insider's view of life in the intensive care unit, of being a medical student, coming up through the system, and all of the complexities and complications and some of the absurdities of healthcare in New Zealand and some ways that it can be improved. So, yeah, this is a man after my own heart. And I hope you buy his book, A Dim Prognosis, and give it a good read because it's unlike any other I've read. Ivor, hello. Good morning. Thanks
Hi.
for joining.
Good evening.
Yeah, good evening. So you're in the UK now, but you are a New Zealand doctor. Is that right?
That's right. Yeah. So I've just gone over for a year basically to do a bit of travel, do a fellowship after I finish my training, and I'll be coming back in about a year's time. So in the UK.
Oh, cool. What's your fellowship in? Your sub-specialization?
Nothing in particular. I'm just working kind of a big intensive care unit in London called St. Thomas's. It's quite like a big quaternary centre, and it does a lot of, it's got a lot of access to various technologies and things that we don't see in New Zealand. So it's kind of cool to see another way of practicing.
So Ivor, can you give us a little bit of an introduction to your path and your career? I noticed in there that you were from the former Yugoslavia, and
That's right.
half my mother's family is from Slovenia, and so I have memories of crossing the border as a really little kid on my uncle's Vespa to go mushroom picking in Yugoslavia back when it was sort of Eastern Bloc. Lots of guards, lots of gates and things. But tell us about your origins and how you ended up in New Zealand and how you ended up in medicine.
So I don't have such memories because I was born around the time that Yugoslavia was breaking up and war was starting. So I was about 2 years old when we moved here. We ended up in New Zealand purely because that was kind of an easy place to get a visa. And actually, I haven't been back for a long time. I recently, before coming to the UK, went on a little trip to Croatia. And that was my first time back in about, 20, 30 years probably.
Wow. And how did you find yourself in medicine, having gone from the sort of immigrant perspective into competitive medicine? How did that happen?
Yeah, well, there's actually a section in my book where I do mention that I'd gone through high school, watched a lot of people who were a few years older than me go into medicine. I watched all the exams they had to do just to get in, and I thought, gee, that sounds really stressful. I don't want to do that ever. But then I kind of found myself, it was kind of more of an accident that I ended up in medicine, really. I ended up coming to the end of high school not really knowing where I wanted to be or what I wanted to do. And I knew I was good at science. I knew I could kind of talk to people on some level. And so I thought, let's give medicine a try. Had no idea what I was in for. It was a completely, as I said, almost floated into it. But it turned out well for me. But yeah, it wasn't kind of a planned thing. It was people who'd been wanting to do that since they were small.
In the book, you did a good job of describing how it's like one test after another, kind of like a little hamster wheel. You get done with this, you look forward to the next exam, then training, and then specialty exams, and then your career and your position as a consultant, and then retirement, and then death. It really is almost quite depressing on some level. And so you said, I think in the book, that you just had to learn how to enjoy each moment or each step for its own sake.
Yeah, that's right. You kind of have to learn how to smell the roses along the way. Otherwise, you find yourself, as you've quoted, just constantly waiting to get over the next hurdle, so then you can move on to the next one after that. And then before you know it, 10 years has gone by, and you're like, where did that go?
No, you had a pretty eventful training. You were around for Whakaari White Island. You lived and worked through COVID. It sounds like you've been in some ICUs that may have lost accreditation or that had, big issues with bullying, and you sort of lived through a highly transitional state. And right now with the the funding issues and understaffing and all of that business with the current government. What's your outlook on practicing in New Zealand? Do you intend to return to New Zealand? Do you look forward to practicing here? Is there a little trepidation? What's your thoughts?
Yeah, I mean, my plan is to come back, and I intend on practicing, practicing and staying in New Zealand. I guess part of what like you say, that transitional period was quite interesting, and almost what led me to what was kind of an inspiration to write the book. Because I think I saw from the time that I graduated med school, which was 2015, to the time that I've come to write it, which is 10 years later, I feel like I've seen a great deal of things change for the worse in the system. And I've thought, wow, this is how much I've seen things deteriorate over those 10 years. Then what is my life as a consultant going to look like in another 10 years or another 20 years? And, how much worse will things get as I continue to, and I've got hopefully a long career ahead of me, how much are things going to change? And that was kind of scary to think of where things might be in the future. And that was kind of part of the thing that spurred me on to write a book and kind of put my thoughts out there and do what I could to try and change things in a small way. And yeah, I've done my training through some, I almost thought of myself kind of as the Forrest Gump of of medicine in some way, that I happened to be there for some kind of big things that were big periods, not only in my training, but kind of as part of the history of the country as well.
Yeah, absolutely. So maybe we'll touch on some of those things. Just in chronological order, I'll describe the layout of the book. It's very much like poignant vignettes and notes jotted down in the middle of the night and observations. And so it's a very easy read, because like around every few pages, there's like a completely different story. Highly recommend people get this book. Maybe I'll just put up the Allen and Unwin. These are your publishers here. A Dim Prognosis, Our Health System in Crisis, and a Doctor's View on How to Fix It. What gave you the confidence to think you could write a book? Is that just the overconfidence of a doctor, or had you had some exposure to writing? I know you credit some of the teachers that you've worked with for, showing and not telling and teaching you the art, but how did you get to the point where you thought, hey, I can do this, I can write a book?
It started off really as it initially actually started off more as a creative writing exercise, because I came kind of from a background where I'd done a lot of creating writing. Then during the time of training and doing exams and studying, that kind of fell off the perch, and I wanted to reclaim some of that, reclaim that hobby in some way. And so I thought, I'm near the end of my training, I'll pick up writing again. And there's a famous writer who said, don't write for the sake of writing, pick something that you know about, and then you'll write about that well. And so I wrote about the thing that I knew how to write most about, which was medicine. And so it really started as purely a way of putting down stories that were, my frustrations or my observations, that were meant to be humorous and never meant to be read by anybody. Before I knew it, I'd written quite a lot. And at the time that I was writing, that was a period of time where there was a lot of media attention, a lot of stories, a lot of news articles on the deteriorating state of the healthcare system. I think one of the first ones I remember from that time was, people saying, my father died after waiting in the ED waiting room for 16 hours. And I started to see how much those stories that were coming out of the news were associated with the things that I was starting to write down. And that's when I kind of realized this. And at that point, I still didn't really intend for it to be published, but I realized, well, these stories could provide an avenue for putting on display some of those problems. Sooner or later, it got to a point where I'd written about a third of the end of the, the total amount of the book. I'd written about 20,000 words. And I kind of thought, well, that's quite a lot. It's kind of, would be nice to see if someone actually wants to publish this. And I wouldn't say I approached it with any confidence at all. I had a lot of trepidation for most of it, to be honest, especially after they accepted it and then gave me a contract and said I had to write the remaining 2/3 of the book in the next 3 months. That was quite a tight deadline. And then I think...
And so you did this while you were training in intensive care, or did you need to take a leave of absence away from it, or did you just do this at night?
No, I just did this kind of after work, after hours at night.
Wow.
Started writing. The whole book took me about a year, so I wrote it. It was mostly through 2024 that I wrote it. Yeah, it took up a lot of my time. My wife was quite happy when I finished it.
So I'm sure she would be. Like, you can sort of focus some attention back on family and other pursuits finally. But we're glad you did write it. From my own point of view, it mirrors some of the observations probably any doctor in the public system would have had. You touch on the challenges facing general practice or emergency medicine or the surgical specialties or intensive care. You talk about the state of IT, essentially the being all a goddamn mess. And I think there's probably a few thousand public hospital doctors that would that would read these lines and see themselves in it. So, I want to thank you on behalf of us for having written this book. Can you talk about some of these things, like, that what are the IT failures that you see and live through, and that are just a reality? Because I think a lot of normal, regular folks would have no idea about getting a patient's info from somewhere else, or the amount of time and breakdowns that occur. I don't think this happens in any normal business I've ever been exposed to. Certainly, it wouldn't be tolerated for more than a few minutes in a commercial setting. But can you just talk about that? Some of these issues that you've noted.
Yeah, I mean, you're right. Absolutely, the amount of failures and breakdowns are, as you said, in a commercial area would be fixed the next day. I think you can kind of break them down into the more menial everyday things, and I think I try to capture that in a lot of stories. I kind of throw in this kind of side point. I'm trying to, I've got 20 patients to see. I'm trying to do this, and in the middle of this, the program that has the waiting list of all the patients breaks down, and I have to restart it, and I count exactly how long, 2 minutes and 23 seconds to restart the program, which is at 2 minutes and 23 seconds that 3 other jobs pile in that time. So there's a kind of menial everyday things that are just kind of a nuisance, from having to use fax machines up until relatively recently in my training. Those only went out of fashion probably a few years ago. And I make a comment about not really knowing you fax off a referral, and you have no idea whether that patient will get that follow-up that you faxed for, or whether that fax has been lost somewhere in the system. You have no way of knowing or following up. So
there's just a tremendous amount of double handling, isn't there, where you have to go and do the paper form because you're not sure if the digital one went through, and just this limbo and really waste within the system. And at the end of the day, you talk about how a lot of it just comes down to money. If you are not willing to invest in the system, you end up in some ways almost doubling the work and the expense. Right? When you understaff and underhire, it's not like you really save money if you're burning through staff, if you don't have theaters that work. Do you see a lot of this coming down to funding at the end of the day? I think you allude to that a few times.
Yeah, I mean, I think just sticking to the, I guess, talking in it from the perspective of the IT theme. Those little things and then compound, and you have the big IT problems, which are, on the night of Fakadi, I have 12 new burns patients come from all over the country, and I have no way to access any of the records of anything that's happened to them before they've arrived, because there's no integrated IT system, and so I have to sit there for hours flicking through pages of handwritten notes, some of them impossible to read. So those are those big problems that as well. I guess that on the question of funding, I think most of it, I felt kind of like a bit of a broken record in the book, because every kind of anecdote that I share, or every problem that I bring up, it kind of ends with variations of, well, there's no free lunch, or it all comes down to money, and all these kind of things. And I feel like I'm kind of beating a very simplistic drum. But I mean, when you fail to make that very basic step, you can't really talk about the best ways to be efficient with your allocation of resources, the best ways to be efficient with spending money, when the fundamental first step of having enough is not there. And I think part of it is just people don't often realize how much that investment needs to grow just to keep up with where we're at. I make a point several times, the over 65 population has doubled, or will have doubled, between the year 2000 and 2030. In fact, it's increasing even faster than we expect. I talk about the increasingly complicated treatments that we're offering more and more people. And so the rise of those costs are exponential. And so unless you invest in a way that's also exponential, you're falling behind every year. I think part of the, people often ask me, well, where do you expect all this money to come from? Like, where do you, who's going to pay for all this? Where does all this come from? And I think that's we'll have an answer for that, but I think that's a even broader topic, because I think we need to start viewing the money that we spend not as an expenditure and not as a waste, but actually as an investment, which is in time going to generate its own return. So I think we need to start thinking differently about the way that we're viewing funding. I think a lot of people, including the government, view it as kind of, well, it's a matter of black and red balancing books, limiting expenditure, but actually it's not expenditure and it's investment.
And I mean, if you think that healthcare is expensive, it doesn't hold a candle to the expense of illness, debility, lost work, underproductivity. I mean, I think dental care is a great example that's really easily understood by people. The cost of setting up a dental for all program in the country, which would give free public basic dental care to everyone, is the total setup cost is probably half as much in terms of dollars as was set aside to help landlords have cheaper mortgages, and just over the next 4 years. And so, like, it's not like the money's not being spent. The money is there. It's just going to other priorities, whether that's 300 million to a tobacco company or landlords or attempts to lower corporate tax rates. I mean, all of these are hundreds of millions, if not in the low billions of dollars. And on the flip side, we've got people suffering the most abject need. You talk about rheumatic fever and rheumatic heart disease. Problems of overcrowding and poor housing, moldy, cold, uninsulated housing, really poor quality rentals that lead children to need open heart surgeries and multiple valve replacements. Some live, some die. Many live with disability and sickness for the rest of their life. And if you think about the cost, what is the cost of lifelong asthma and bronchiectasis in children that will impede their ability to do anything for the next 50 years, or meningococcemia or rheumatic heart disease? So I think a lot of your book goes to social determinants of health, this idea that it's not just about the medicines, it's about like the whole home situation and poverty reduction. Do you want to say anything more about that? Like, what are your thoughts on social determinants of health and ways that we can deal with reducing poverty, especially child poverty in the country? Have you given that any thought, or is that book number 2 for you?
Yeah, that might be. I need to have a follow-up of some sort. I think, I try and really distinguish the fact that the earlier you go on in the chain, the more investing in that part of the healthcare produces in the end. And I make the point, one good GP is worth more than 10 good intensive care doctors, just because of the amount of people they can reach and influence. And even if you take it back to kind of what you're talking about in terms of spending in the economy, even if you take it back to just looking at, we care about people's health and we care about their well-being, but even if you're to look at it from a purely economical point of view, sick and dying people can't work and they can't contribute. So even if you look at it from that particular point of view, we need the population to be healthy. I think it's the question of child poverty. It's not one with an easy, straightforward fix. But I think the housing situation is probably where you can. I think, struggling to remember if I wrote this particularly in that chapter, but I said I think housing, education, and disposable incomes are the three things that have been proven to lift people out of poverty. And I think actually it was the disposable income of the parents is the greatest predictor of the poverty of the next generation. So I think anything that we can do to lift that up is going to be effective now. You could probably write a whole other book about how to tackle that issue, but those are my overall thoughts.
Yeah. I mean, part of this podcast is to talk to people about these issues and raise awareness and see if there are people proposing solutions. So, we had Ed Miller on here a few months ago talking about how some of the biggest corporations in the world, some of the most profitable ones, Meta and Uber, hide 90% of their profits in offshore tax havens to avoid being taxed. So there's some low-hanging fruit there that I say we, but that governments really have been loath to go after. But I think it is reaching a tipping point where, if we've got doctors like yourself, and many, many others willing to speak up about this, that it's gotten pretty far through the society. Like, it's affecting middle-class folks if even some of the private doctors are complaining about the unfairness of the system and how it needs to be changed. I think it is reaching a tipping point. Now, one interesting thing to me and to any doctor any medical person that reads this is that you weren't afraid to criticize the profession and to talk about some of the let's say the bullying episodes where, you did a really good job of describing how belittling some consultants can be to their juniors, essentially feeling like, I went through this, now you have to too. How that ends up compromising patient care, obviously, at times. You talk about some of the gaming that the system does with the health system essentially putting consultants' names to cover registrar vacancies, even though the work isn't in actuality being done. What else did I write down here? Talking about how consultants who have very procedural specialties, let's say a surgeon, can more easily go into the private sector and can use that as a bit of a bargaining chip in terms of pay, reimbursement, or working conditions. And how in some cases consultants wouldn't have seen patients in the hospital for days. And you point to a few cases where other consultants would be willing to call that out and say, like, where was this guy while they were at their private clinic? And you make the point that these doctors are working both in public and private. There isn't really a huge pool of purely private docs out there. And this idea that, let's say Simeon Brown wanting to change Health New Zealand and change the medical system so that privatization happens and more cases get done in private, it's not like there's a separate pool of doctors just sitting around and waiting to take care of people. It's the same pool. So this privatization ultimately really isn't going to work. It's going to pull doctors out of public and into private. So I am proud of you for being willing to talk about these deep and deeply seated problems in the system. Were you scared about mentioning these issues? How did you go about that? How did you tackle that aspect of, like, the whistleblowing aspect of writing a book like this?
Yeah, that was I did devote a significant amount of effort to worry, I should say, to thinking about that. I thought it was important to talk about that aspect because if you just spend the whole book talking about funding and the economics of it, which is very, very important and probably the most important part, but you're going to lose people eventually because nobody's going to read 250 pages of just about healthcare funding. And so I thought it was important to cast. I kind of described I cast the book in casting those responsibility in three different groups of people. Number one was the people above us, the administrators, the government funding, and so on. That was a big aspect. But number two, I thought we really need to look internally as well and take responsibility for the things that we as a profession and internally can change and make better. there was some of those aspects, like talking about the selection onto like surgical training, for example, and who decides how many spots are offered each year. Things about specific examples of bullying, the stories that I told. Things like that were, I had to be very careful about how I wrote those stories. The main bit is that you don't want to write anything that's going to be recognizable, so that's going to identify that person, because that leaves you open to defamation. And so you have, I went through a big legal review with the publishers. They had a lawyer who works for them who goes through and they flag up everything that could potentially be a legal issue, and you kind of talk through it and you find ways to mitigate that. Nevertheless, I still felt that some of the, bigger, the more, not necessarily when I'm talking about individuals, but talking about the behavior of groups of people, whether that could result in some kickback or some, some angry emails or letters or anything, or future repercussions for my career, that did weigh on my mind. So far, that seems to be okay. But at the end of the day, what helped me through that was, whenever I'd get to a point where I think, Jesus, is this, should I not be doing this? I would think to myself, what am I going to regret more in the future? Am I going to regret not talking about this? Or am I going to regret talking about it and getting in trouble? And the answer was always, I'm going to regret not talking about it more. And so once I framed the question in that way, it was very, even though I knew there was always a risk, it became very clear what the right thing to do was.
That's awesome. I feel like you're sort of the younger version of me trying to draw some attention to things, but with a much greater gift for writing and storytelling. And it should be pointed out that you don't hesitate in this book to criticize yourself. You're not spared from criticism. You talk about the sort of dehumanization that happens to a young doctor in training who is working as fast as they can all night without sleep, watching their phone accumulate jobs. So as soon as you put out one fire, a person collapsed, or someone needing an IV, or an order for blood that someone forgot to write, the whole time you're doing that, the number's ticking up. So this is a very great scene, one of your chapters, about, I think the number maybe gets over 100 jobs that you have, where you just tangibly feel this person sinking under the weight of it all. And then at one point, I don't know if it's in that chapter or a different one, you talked about essentially you being short with other staff. Like you do get to the point where it's almost like this, I've got to survive the night mentality. And I think that's part of the dehumanization of an overstressed system, is that people are forced to do things that they wouldn't do, and to become people that they don't want to be, just in order to make it through till morning.
Yeah, I think the line I say in the book is, everybody has a threshold where they become an asshole, where the lower they're dealing with in their capacity to deal with it, the math goes the other way, and different people have different thresholds, but everybody reaches it eventually. Like you've pointed out, I talked to people in ways and acted in ways that I didn't think before I entered medicine I could talk to someone in that way, and I was deeply disappointed in myself afterwards. And I think that's just that's part of the problem also, is not just when you have a system that's overstressed, under-resourced, it's not just an effect on the patients and the care that they get, but it also affects the staff in a similar way. It affects their mental well-being. It affects the nature of the interactions that you have, the professionalism in those interactions, and all those things additionally then flow on to affect the patient. Because, as I mentioned in one of the chapters about bullying, it's not enough just to know all the medical facts and know exactly what the right thing to do is. If you can't communicate with the rest of the team and they don't know what you want and what's on your mind, then you can have all the greatest plans in the world, but it's not going to come to any fruition.
at one point you talk about this realization when I guess you're the first time you realize you've fucked up with a patient and caused them harm. I think you describe it as like the same feeling that you might have when you lose your child at the mall, and in one split second, all the worst thoughts about humanity, about yourself, about everything goes flooding through, and you get this very visceral fear, like the pounding of the heart, the whole adrenaline release. And I think a lot of doctors would read that and absolutely recognize that feeling the first time they realized they screwed up, and it really hit them, like the enormity of what they're doing. And I think in a way it's a good thing that there are still doctors out there who care enough to be really affected by the work they do on a day-to-day basis. And it's not just some job you go to, you get a paycheck, you go home. You take the work home with you, and you're thinking about it all day and every day. Yeah, I guess a big responsibility, big privilege, and it comes through in the book. So it's good to know that there's a new generation of docs coming up who still feel that way. Um, can you just talk about for a second the whether you've noticed any intergenerational shifts between the way doctors do things, let's say in my generation and the new grads coming up through med school nowadays? Like, what do you think has changed? Has anything changed, or is it fundamentally at its core the same?
I think even though there's a lot of, I think overall, even though there's lots of chapters where I talk about the bullying and the bad treatment, I think overall, probably over time, the tolerance of that behavior has become less. So I think I think still there's lots of it, unacceptable amounts, but I think the willingness of people to call it out and tolerate it has become a little bit less. I do think that it's kind of hard to know sometimes because, as I mentioned in the book, every generation wants to kind of wear its own things they went through as kind of a badge of honor. So sometimes, you compare things you had to go through as a newly graduated doctor, and you compare it to the current group of doctors, and you think, well, they have it easier than I did. But it's not. It's so hard to know whether it's just you, having that false memory and wanting that to be the case versus if that's actually the case. So I think it's in terms of kind of the workload and the way of practicing. I think hard to say. I think in terms of some of the interprofessional skills, probably overall better. That would be my kind of very crude assessment of it.
Yeah, I think I would agree that it's just different in many ways, not necessarily better or worse. And it's probably not a productive thing for generations to get into, like, intergenerational criticism, because at the end of the day, it becomes sort of a pity party of my life was worse than yours, or my time was harder than yours. And I think the reality now is the pace of patient flow is just so incredibly fast, and people are so sick that in some ways it's almost like a different hospital than it would have been 40 years ago. I think in the 80s, New Zealand had, I think it might have been 12 beds per thousand, and now it's down to about 3 hospital beds per thousand. So if the dynamic has really shifted and it is continuing to shift. It's interesting, like where will this all end up in 10 years or even 5 years? It's really hard to say. I wanted to just read out this little bit, just a paragraph or two. It was from your chapter, Public, Private, and Profit, and it was talking about how there is a two-tier system in New Zealand already between patients who do have access to private doctors, whether they pay out of pocket or have private health insurance, and those who don't. You say, I strode briskly, trying to contain the bristling sensation that was building up under my skin. I pondered how the cardiologist would respond if this was Miss Lyle's first presentation with SVT, and I had suggested doing all those tests in the public system, they would probably laugh at me and hang up the phone. She'd be lucky to even get half those tests done. It's just so fucking unfair. Specialists like to wax philosophical to junior doctors about relying on your clinical skills rather than ordering tests until they stand to profit from such tests. Funny how clinical judgment can change depending on incentives. So we're all just humans, right? We all respond to incentives. And the way we've set this system up is to reward the person who can whip out procedure after procedure in the private sector. And we have created this system where I find it quite fascinating that a patient will have a complication in private, let's say after a surgery, and they will get rushed to the public system and essentially get bumped to the head of some lists, because all of a sudden it's Mr. Smith's private patient with the blood clot in their lungs after the surgery. And you will have a certain level of attentiveness and rapid response that you wouldn't see if this was, Bob from down the road who's coming in and is in the waiting room waiting for 4 hours to get seen with his query PE. So it is so fucking unfair, and I love that you weren't afraid to point it out. What do you think about the whole two-tier system, and like where is it going to go in the future in your mind as a young doctor?
Yeah, well, I mean, I've seen similar things, which I didn't mention this in the book, but there was one instance of a patient who had been referred in from the private clinic, and they were told they needed to be admitted straight to the cardiology ward for something simple. That for any person who just turned up primarily to the hospital would never get near a cardiology ward. Be managed on the general medical wards, but this person was kind of shoehorned straight away because it was that person's private patient. And the thing that's even more bullshit than the test story is that particular part of the story. That's a story about two separate patients, both with similar kind of problems. One has been waiting for an echocardiogram for a year in the public system, doesn't get it, falls over from her untreated condition and breaks her arm. And this other woman has gotten all these tests in the matter of 3 or 4 months. And then, but the added then that happens is that I go and I think, well, I've seen all these patients, I better discuss them with the specialist who's ultimately making the decisions, not me. I'm just the go-between. And I call him up and he says, well, he's on call in the public system, but he says to me, I'm just in my private clinic this morning. Can you call back after lunch? So not only is there separately from the division of public and private, there's also a double dipping that's going on, where even patients that should be being looked after in the public system, there are people, and it's not the majority, but it is a significant enough minority who are then double dipping and getting their private time in at the same time. So that compounds that unfairness.
Which for people listening in who don't know, that's not actually legal to be on call for one thing and working your private clinic job at the same time. That's not how it's supposed to go. It's ethically not permissible and legally and contractually not allowed. But something, I guess, that maybe just they turn a blind eye to, because there is quite a bit of power. There are some groups in hospitals that you don't want to piss off because they do bring in, let's say, ACC funding or private money or what have you. And yeah, there really is a two-tiered system. You just don't learn about it until you've been within the system for a little while. 2 tiers for patients, also 2 tiers among clinicians, among the doctors as well. Yeah. Problematic. Let's get to solutions now, though. I like to spend these shows also talking about how to fix the problem. So at the back of your book, let's see, where was this? Very back. You saved the best for last. Okay, you talk about a bottleneck to specialist training, and all of these people essentially stuck at the house officer level early in their training, not able to get on a training scheme. Now, the numbers of doctors allowed into training is not controlled by the government. It's controlled by the specialist colleges. So in my case, I'm a FASEM, a fellow of the Australasian College for Emergency Medicine. That college, that nonprofit organization, housed in Australia and shared with New Zealand, decides how many people will be allowed into specialty training. Now, for some specialties, there's a desperate and profound need for the doctor, that kind of doctor, maybe a urologist, an ophthalmologist, or what have you. And yet the numbers are infinitesimally small that can get in every year. You talk about some years, maybe there might be 0 to 1 trainee getting on these training schemes nationally, meaning that year they will pump out 0 to 1, let's say, ophthalmologists or plastic surgeons. Have you given any thought to how we get around that, how we break the hold, the stranglehold that the specialty colleges have on the creation of specialists and the numbers that get through? Have you given that any thought?
Yeah, I think it's a hard one. I think when it comes to the number of training positions, I mean, part of the problem is it's really hard to find any firm data on how the process actually works. It's very murky to anybody who's not, I guess, within that and doing that. And so we know that it's partly determined by the number of government-funded training positions, but we know where that intersects with what the college decides is anybody's guess. And part of the thing I say in the book is, well, is it possible that there's an element of restricting spots in order to limit competition? I don't know. There's no proof of that. There's been some investigations in the past on that topic. No, that's never been proven as being the case, but it's just a question I raise. So I guess it depends. The first thing we need to know is actually in order to tackle the problem, we need to understand how this all works. How do these murky workings all work? And if we can identify that the major part is the stronghold of a college on the number of training positions, then there needs to be a way to open it up to more scrutiny, I think. And if we find actually the major limitation is the colleges want to have more, but the government's not providing enough funding for those funded training positions, then we know that's where we need to target our interventions. So it depends a little bit on finding out a bit more about how it all works and then knowing which part of that equation to address.
That reminds me of an interesting point you raised in one of the chapters on nursing, how government, for example, will say, we've hired 3,000 nurses, but they won't point out how many they've lost. Or we've hired 3,000 nurses, but they won't point out how many more we actually need. I think that the numbers a couple of years ago were 4,500 nationally and a few thousand specialist doctors across the country. You do make the point that we don't know where we stand because we don't want to collect and publish the numbers on real need. How many doctors do we need in this or that department? You quote some numbers of like 22% shortages of specialists nationwide, but those numbers really ought to be publicly available, hospital by hospital. You should be able to look right now, look up, let's say, Auckland City Hospital, and see what their staffing is like versus my hospital or your hospital. But those numbers are not not transparent. Like, we don't get to see them, and we don't really know. And that's part of the reason why politicians can so effectively say, well, doctors make an average of 325,000, and each. And then the doctors, laugh and scoff at that idea and say, what are you talking about? That's like, half. I'd make half of that. What are you talking about? It's quite interesting to me, like, that we talk about these problems for so long and for so many years, and yet we can't even agree what the problem really is. We talk about hiring all these nurses, but then you point out alarmingly that a lot of the nurses that we've quote unquote hired, those numbers actually come from the numbers that get professional licensure, and that doesn't always equate to the numbers that are actually working within the system. So we've got hundreds, if not thousands, of nurses that come from abroad, and that get a license here, but then they're told they can't be hired within the system due to incompatibility issues or training issues or what have you. So, yeah, it seems quite dysfunctional, doesn't it?
Yeah, well, I think there's probably a purposeful misrepresentation of what the numbers mean. So there's nobody's told an outright lie, but it's more like, well, we talk about the nursing, we say, well, we've given this many professional registration, leaving out the fact that, well, that doesn't translate into the number you've hired. And then even on the Te Whatu Ora website, they use this method to calculate the amount of FTE shortages in medical, physio, allied health, and nursing, and they use the same methodology in all of those. Except when it came to nurses, they said, oh, we have the shortfall of so many thousand nurses. But actually, that's not accurate because we know that we already have enough nurses to meet general need. So they use this very circular logic, like we've done some internal calculations, and so our methodology is not actually accurate, even though it's accurate for the other professions.
Right.
And there's no way to know what, how they've come to this conclusion. It's not available, as you say. It's there's no way of knowing whether this is just a statement of numbers that have been made up or whether somebody's actually done some number crunching. Completely unknown. And it's funny because it gets back to it.
Yeah.
Sorry, go ahead. It actually relates. It's funny that you mentioned that kind of there's so much information that's not available. I was actually today writing an article about the end of last month they announced all the health targets and how everything appears to be on the up. And you can, if you want to find information on the health targets, it's very easy. You type it into Google. It's the first thing that comes up. You get these nice graphs. But if you want to find anything else related to those, it's impossible. We see the number of first specialist appointments has evidently there's less people waiting 4 months, but then there's absolutely no data on how many were referred for first specialist appointments, how many were declined a first specialist appointment. Has the decline rate increased in previous years? We have no idea because any data that's not immediately relevant to the picture that needs to be portrayed is not there. Similarly, what was the other? There was something else that it escapes me now. But there's that recent report about cardiac healthcare, and we've seen that in the last 10 years, from the time that you have an MI to the time you get an angiogram or all those targets that we have, those have gotten worse in the last 10 years. And yet, are we collecting data on draw to needle times by quarter? No. Are we publishing it? No. Is it easy to find? No, it's not anywhere. So there's all this rich information that we should know and would need to know, which is just not there.
And then you compound it with all the public-private stuff now. The Simeon's privatization of these surgical cases. Well, the first question is, are we getting value for money? Like, what are we getting for our dollars? And the immediate answer by politicians will always be, we can't tell you. It's a commercially sensitive topic. It's essentially a trade secret. We can't tell you. Well, the hell you can't. This is the government collecting our tax dollars and using our tax money to buy a service for us, for the public, for citizens. Of course you can show us the funds and the money and show us the numbers. We need to know exactly what's going on. The
most of you know is that it is more expensive to do the same, to provide the same service in private than it is to expand the public system.
Absolutely. Because you've got to, for one, you lose all that money to the profit margin. So whatever profits they're making, 5% or 35% or whatever it is, that money is not going into patient care. It's going into an investor's pocket, which is why these healthcare corporations are investing, these private equity firms in Sydney and other places internationally are investing in private healthcare in New Zealand because they know these radiology private practices are printing money. Whether it's telehealth, whether it's a private hospital, a surgery center, an endoscopy lab, we lose. We're hollowing out the public sector to enrich a small group of people. And at a minimum, we should at least have transparency. I don't know if you saw what the ombudsman said to the government. They forced the government to apologize because about a year and a half ago, the nurses were saying, we can't fill positions. There's a hiring freeze on. we've got people going away on maternity and retiring, and we're not allowed to even advertise to fill these nursing positions, and they're desperately needed. And politicians in government were saying it's not true. Like, we've hired more than ever. We've hired 3,000 new nurses, and in fact, we have overhired and overstaffed in some cases. And all the regular nurses, that you talk to were like, this doesn't meet any reality that I see on the ground. It took about a year and a half, but the ombudsman's office investigated the complaint and eventually found government had been lying. Government had been acting, quote unquote, unlawfully in not releasing or delaying the release of a lot of this data, of not making it public, of misrepresenting it. And finally, when it came out, they said, well, no, there actually is a lot of nursing shortage, a dangerous level of nursing understaffing. And again, the ombudsman made them apologize. But, getting an apology a year and a half later doesn't fix care for actual patients. So, yeah, we need more transparency. We need more doctors like you willing to speak up. What are your thoughts on the doctors you have seen that are nationally, whether it's Nelson Hospital, Topol, Hawke's Bay? Like, where do you see this going? Do you see this becoming a movement? Do you see hope?
Yeah, I think so. I've seen a lot of. I think one thing that's helpful is the amount of reporting I'm seeing generally on these kind of issues, and I see, in the last month, a lot of things reporting on the same kind of things I've talked about in my book, and so it's encouraging that there's more of that going on. I'm seeing a lot of colleagues, some who I don't know and some who I do know, going on radio and giving their piece, and then some of them are getting in trouble for it, and so I think there's a more willingness to talk about these things. So I think that's good. Whether that will translate into people listening and things changing, I hope so.
Now, you had said you read an article I had put out, I don't know when, probably even a couple of years ago now, a year and a half ago, about speaking out. So can you talk to that for a second? I'm going to link that article to this because it was heartwarming to read your email about it, because I really don't know the impact any of this stuff is having, whether it's this podcast or the Substack stuff or the interviews. But like, to read what you said made me think at least it reached and helped one person. So it was worth it. Like, it was worth doing.
Yeah, I mean, I'm probably about to butcher what you wrote, but the main it was the period of time where I was kind of, I was in the middle of, had not quite finished the book, and I reached out to my publisher and I said, well, in terms of these things that I'm bringing up, what are the kind of, I'm not allowed to. There's a specific line in the ASMS contract which says you can't say anything that's going to bring. You can't say anything that's going to bring the organization into disrepute, or something that's new, that you haven't brought up with them before. And my publisher forwarded me onto your article, and that was kind of basically talking about the fact that not only is there within the contract a protected right and even a responsibility to speak up about things, but also that there was a lot of protection in the things that were, if things had already been raised in general about a specific issue, that kind of afforded you the fact that had been brought up before, and that was something you could then go on to talk about. That was kind of, so provided me a lot of reassurance, basically, about the things that I was saying and that I was doing, that not only was that okay, but in some ways that was also my responsibility to do that if I'd noticed those things. Correct me if I've kind of...
No, you got it. You got it absolutely right. And a decade ago or more, 15 years ago, when these rules were being put out, the idea was put forth that having doctors willing, like yourself, willing to speak up about things is actually good for Health New Zealand. It's good for the country. It's good for society, because it puts a light on an issue so that we can then fix it. And if anything, you have an insight, a personal lived experience into this that very few people in New Zealand have. And what your comments note are really important things that we as a society need to be working on. And so, yeah, the idea is that being a whistleblower should actually help make the system more robust, more fair, and better. And at the same time, the rule that you refer to is the idea that it's not fair to any employer to read about something in the newspaper for the first time ever. What we should be doing as responsible employees of any kind is bringing this up with management, bringing it up with, higher level management if you need to, or any of your hierarchical structure at work, so that they might fix it and that they might address the problem. The flip side to that also, though, is if you see problems that aren't getting solved, that are publicly known, that are maybe reported about in the newspaper, which I think is a really easy thing that doctors can do. We can talk about things that are actually already out in the public view, comment on them, and give our opinion and our perspective. And I think that is necessary because, like, I live in and work in a very poor and underrepresented part of New Zealand. I'm in Northland. There's there's a large segment of our patients up here who don't have a lot of money, a lot of power, authority, or health literacy, or sometimes agency. And so the ability to speak up on behalf of them, if it doesn't come from the nurses and allied health and doctors, who is it going to come from? And yeah, I think it is incumbent on us as healthcare professionals to do more than just observe problems year after year. It's up to us to try to fix them, and if they can't be fixed, to raise the discussion to a level where it can be addressed. Let's end on a positive note. I call this the most depressing podcast on YouTube, but let's because we're always talking about big systemic issues and problems. But let's end on a bit of a positive note. Where could you, Ivor, see us ending up in 10 years? What does better look like for the health system that you want to work in, the ICU that you want to care for patients in? What would that look like?
I think the first thing that would be, excuse me, being in the ICU, we're relatively protected sometimes from these kind of whole system things that become more apparent in other parts of the hospital. One of the first things that I'll split into immediately in the environment where I work and then more widely. I think the biggest thing that we notice is, number one, our nurses always getting redeployed because there's as you said on that ombudsman report, there's a X percentage shortage of shifts every time. And so it's not enough nurses in ED. They get redeployed to a different environment where they're not familiar with, and it's a risk to them. So first thing we'd see is that's not happening. And the second thing, we won't have patients sitting around in the ICU for days and days and being ready to be discharged straight from the ICU because they can't access a bed on the ward. So that's going to free up more ICU beds for other people who need it. And it's going to be better for those patients as well. So that's the first thing that it's going to look like for me. But I think more generally that we're going to see a reduction in bed block and overcrowding in general in all parts, especially in the ED where you work. We're going to see better access to services in the community that are going to let people get things handled outside of hospital and keep them out of hospital. So better health in the community, so we stop things early before they even turn up. Being able to access things like rest homes and palliative care and private hospitals, all of things in the community without having to spend weeks in hospital. So I think an improvement in patients' experience, their feelings of ease of accessing the system, because at the moment a recent survey showed that over time people are finding it more and more difficult to access healthcare, access their GPs, number of people not going to their GP because they don't have the time or money or are able to access all those things. So we see patients' ability to access the system, their ease of accessing the system getting better. the amount of overcrowding and lack of access within hospitals getting better, and hopefully that will be reflected in some of the, we talk about this health targets. Hopefully that will be reflected in those things that we measure without having to go out and chase them artificially. We will actually see when we invest properly in the system and we address the underlying problems, those things are going to rise and improve by themselves without having to focus too much on them.
That would be a wonderful world. I hope we can get there. I mean, at the end of the day, it sounds like you would just like an ICU that works as it's supposed to. It's not too much to ask for. Just, yeah. I'm going to read the last 3 paragraphs of your book, and then we'll end this wonderful interview, Ivor. Patients also need to realize that medicine is an art as well as a science, and that while doctors and nurses will do their utmost, they are not superhuman. There is money in the government coffers. New Zealand is a first world country. It's a question of priorities. Investing in the future health of our population at large would come back to society tenfold. If we are not investing, we are destroying. With the right therapy and lifestyle changes, the condition is still reversible. It is up to all of us. Ivor Popovich, Dim Prognosis. Thank you for writing this book, and we look forward to part 2, the sequel. Thanks for your time.
No worries.
Yeah,
thank you.
You've got a few other things on your plate now. Thanks for coming on.
I had a great time.
Oh, it's my pleasure. I hope everybody in healthcare, everybody who's a patient, everybody who interacts with this system will read your book. A lot of insights in there, and most of all, I feel like this should go out to every politician in government right now or in opposition, just as background reading for the health system. It's a really great book. I thank you for writing it. Thank you, Ivor. Say hi to your wife, Sarah, and hope you can get back to leading a somewhat normal life now as an ICU doctor. Are you fully qualified and graduated? Are you all done, 100%?
All done, yeah. I got my letters in August. Yeah,
beautiful. Right, congratulations, man.
Thank you.
All right, see you around. Thanks for coming on the
Bye.
show. So thank you for joining me on the front line today. That was Ivor Popovich, A Dim Prognosis, Our Health System in Crisis, and a Doctor's View on How to Fix It. Yeah, I'm not going to hide the fact that I love what he's done. I hope there are more doctors out there in the world like him, and it gives me great hope that the next generation coming up will fix some of the problems we have saddled them with. Yeah, join us next time on the front line. If you like stories like this one, interviews like this, please subscribe. And more importantly, just share it with even one friend. It goes a long way. And hopefully we can change the system. See you next time.